we found that around 4.4% of our patients are found to be thyroid positive, and this thyroid positivity is mostly consistent with depressive disorder. And if I talk about the another picture of this thyroid dysfunction, then we are getting more cases of hyperthyroid condition. Those comes with manic episode or polymorphic psychosis.
As an extension to the question, either to you or to Saurabh, my question would be that would we have a patient with depression and we do a thyroid test and it comes out to be subclinical hypothyroid, and the TSH level is between 5 to 10. So would we treat the subclinical hypothyroidism, or would we wait for, like in any other situation, the endocrinologist would like to wait for a second blood test after say 6 weeks to see whether the TSH levels are climbing up, and also do a 3T4 to check whether there is a possibility of an established hypothyroidism, subclinical but established hypothyroidism. So would we?
I would like to take this question. So actually, what I feel from my limited experience is that a lot depends upon whether the patients what kind of symptoms they are presenting. It is very often seen that patients who are having TSH level between 5 to 10, they do present with certain symptoms of hypothyroidism, even if they are TSH are normal. So in those cases, there is absolutely no doubt we should start or initiate thyroxine. Now the question becomes more difficult when there are no symptoms per se, but there are depression is there, but the TSH level between 5 to 10. In those cases, what I personally do is that if I see that the patient's depression is very much in control and the patient is functional, productive, things are fine, then I wait and I ask for a second opinion from an endocrinologist or some general physician. Now, if I see the depression is not responding properly, or there is not appropriate response, or the response level is slow, then I choose to add levothyroxine, because we know that levothyroxine has also been known as an agent to augment depression treatment. So that is my take on this subject.
I do agree, and my response is straightforward. So it's a valid and it's an established fact that thyroxine can be used as augmentative therapy in resistant depression. So any patient, if there is subclinical hypothyroidism, we should go for thyroxine add-on and following up the patient.
So if I complicate it further and say that you add the thyroid, and even if, the person is going into a category of treatment-resistant depression, and now you think that lithium is an ideal choice, a molecule. So what would you do? Because there's kind of mental depressive episodes which are happening, and it's not reaching the baseline as we said. Response is happening, but remission is not happening either.
So I will go with lithium. But I will monitor the thyroid very strictly, maybe every 4 weeks or so. And if necessary, I will add or keep on increasing the dosage of thyroxine, because lithium affects thyroid system. Lithium worsens thyroid function, that is very well known, but it does not affect greatly. For example, if a person's baseline TSH is at say 3 or 4, adding lithium even at 800 or 900 or 1000 mg per day is unlikely to increase it to a level of 60 or 70 or 80. It will maximum increase it to 10 or 12 or 15. So it doesn't matter. You can just distance 25 to 50 microgram of levothyroxine and get it done away. But on the other hand, if we do not treat the depression or recurrent depression adequately and properly, there is a very high chance of suicide, because as we all know that suicidality increases in cases who have a recurrent depressive symptom, sometimes bipolarity can also be present. So if you look at the effective cost-to-benefit treatment ratio, so this is a much more rational and scientific approach is what I feel. If we add the lithium as a major molecule and monitor the TSH or thyroid levels and deal with it accordingly. And also, if the patient is having any anti-thyroglobulin or like anti-TPO activity, that also complicates matters further, because in those cases there can be some underlying primary thyroid issue. So it is better supported, or it's better to refer such patients for parallel treatment by the endocrinologist.
See, before going for lithium, actually we should explore some other possibilities. We can go for lamotrizine, pramipexole, and or other forms of therapies, because you see patient is already hypothyroid, and if we add lithium, then we are going to inflict further. We are going to inflict another burden of the cost of monitoring the thyroid and cost of the therapies and all. So yeah, we can go for lithium at last, but frequently it will not be advisable, it will not be wise to go for lithium in a condition where hypothyroidism is there or suspected or in borderline condition.
So in treatment-resistant depression, let's take the choice of lithium and lamotrizine.
I would like to add one point here on this Stevens-Johnson syndrome, and that is actually in my practice actually what I have seen is that this lamotrizine has more potential of causing Stevens-Johnson in young females.
Right.
And I had 3 cases, and it creates a really horrible situation. It's so violent eruptions, and it's so violent eruption, and you have to be with the patient, you have to be with the, and you have to have a dermatologist in your team. And other than,
I would like to add here, like given the current socio-political environment in our country and the prevalent mindset against doctors, at least in our where we practice, it becomes an added burden to explain that why I have chosen lamotrizine and something or something else, and why the medicine has caused this crash, and it came up with a lot of huge hospital bill and the risk of life and a lot of other things. So that makes it difficult to explain. So, and what I routinely do that when I prescribe lamotrizine, I always send photographs to the patient that if you see this kind of rash, just please come back to me and stop the medicine. So that is one of the precautionary approach that I take, because I also have seen a lot of, not a lot of, but a few, certainly a significant number of patients having Stevens-Johnson's on lamotrizine.
I was usually in postpartum depression, actually, if we see for the long-term longitudinal follow-up, then it is seen that there is a majority of them ends up with some bipolar type of illness, bipolar type of sickness. Some develop schizoaffective or a very crippling source of mixed anxiety depression that waxes and wanes. So treatment is to be tailor-cut depending on follow-up presentation and on how the patient follows it up. But this is what I have noticed and I've seen in postpartum cases basically.
Okay, so this is veering towards the bipolar. Saurabh, what would be your choice?
So I would like to add a low dose olanzapine to the patient actually. If I see as an augmenting agent and also as a prophylactic, because if the need arises, I can quickly taper off or stop the escitalopram and give the olanzapine, because olanzapine has found to be a very good safety index in postpartum patients and lactating mothers also, and it has a faster onset of action, very easily available, relatively cheap, and is definitely effective.
Okay, Dr. Rezaul, any final comments, because we have to wind up now. It's now 10.
Yeah, it is already late. So discussions were very interesting and very inspiring. Actually, I would just like to take a few seconds to show a very dreaded thing. Actually, basically, if the organizers allow, I would like to show. Actually, I find out the pictures of a Stevens-Johnson's syndrome. That is really horrible. I suppose I would just like to show. Just a sec. It will take a second. So though this is not relevant. So are these pictures are visible? Yeah. This is what you see. This is, and so after, so I stopped sharing actually. Though.
Okay, thank you for sharing those.